I'm Marv Slepian and Jay Zwischenberger with me. We're going to talk about, this is the session 6, K for kinetics. So it's my pleasure to have Dr. Vorovich come up and speak about why is Epi not the drug of choice for cardiogenic shock. Please take it away.
Come on, everybody.
Good afternoon, everybody. I'd like to thank the moderators, and particularly Marwan, for inviting me to speak and for putting on this absolutely wonderful conference. Hold on, let me get my clicker. So today, as mentioned, I'm going to be talking to you about why we should not be using epinephrine as our drug of choice for cardiogenic shock. Here are my disclosures. So epinephrine. So on the surface, theoretically sounds fantastic. We know it's a catecholamine and has high affinity for multiple or all the receptors, alpha 1, beta 1, beta 2. We know it's commonly used in about 20 to 40% of cardiogenic shock patients, depending on which registries you look at. You know, it's often thought of as kind of a quote-unquote high-dose norepinephrine, but I think it's important to point out that it has a much higher affinity for beta 1 and beta 2 receptors, thereby leading to more chronotropy, more inotropy. And it increases MAP significantly, both through those mechanisms as well as through a mechanism of vasoconstriction. And at higher doses, these alpha effects tend to predominate. We also know that it can increase coronary blood flow through relative increase in duration of diastole. But as expected from the title of this talk, and Nir actually stole my thunder by presenting kind of the baseline message of this in his opening talk, is epinephrine has significant downsides. So from a hemodynamics perspective, it increases afterload, which can decrease cardiac output. Particularly at higher doses, it increases PVR and it increases RV afterload. With increased heart rate and stroke work, we have an increase in myocardial oxygen demand. Not surprisingly, with all of the stimulation of the heart, we see increased arrhythmias. There's been shown to have direct cardiac toxicity, both with arterial wall damage and necrosis, as well as direct stimulation of myocyte apoptosis. It can cause hyperglycemia and insulin resistance, has unclear effects on splanchnic and gastric mucosal perfusion. And I think something that often is not talked about is that it can actually lead to a type B lactic acidosis, or lactic acidosis not due to tissue hyperperfusion. Multiple putative mechanisms, and I know David Feldman talked about the importance of basic science, but I'll summarize of it, just a lot of mechanisms, pyruvate being shunted to lactate production, but again, unrelated to tissue perfusion. And here we are using lactate as one of our main metrics, not our only, but one of our key metrics for assessing the adequacy of our support. So let's look a little bit at the data. So this is animal data from rats, and this is looking at hemodynamic effects of 3 pressors. Norepi in red, epi in blue, and phenylephrine in green. Panel on your guys' left is cardiac output, right? And not surprisingly, NEO drops cardiac output. That's not the point of this talk, and as expected. But cardiac output goes up a pretty decent amount, particularly at 1 hour between norepi and epi. But what we see in the middle panel is that comes with a significant increase in heart rate. And in the panel all the way on the right, it comes with a significant increase in pressure volume area or stroke work or myocardial oxygen demand. So it increases cardiac output to a similar degree, but causes an increase in myocardial oxygen demand. And one of the mechanisms of this is tachycardia. How about data in humans? So this is a randomized trial, now seems super old. It's amazing how old the graphics look, only 15 years ago. Of a little under 300 patients, all comers with shock, not necessarily cardiogenic, but approximately half had cardiogenic shock. Their primary goal was MAP. And what in the epinephrine is the black squares. Epi and norepi showed a similar effect on MAP in the bottom left. But again, as I showed on the prior slide in animals, in rat model, in humans, we saw an increase in heart rate, an increase in lactate, and an increase in insulin dose required. Particularly in the first 24 hours, that did seem to settle out. This led to a pilot study later, small study, 30 patients randomized, of patients with cardiogenic shock not responsive to dopa or dobutamine that were non-acute MI shock. And they were randomized to epi versus norepi and dobutamine. On the panel in the top left and the middle left, you see that MAP and cardiac index are pretty similar between the two lines. But again, you see this higher lactate, this higher heart rate on the right. And interestingly, you see less diuresis with epinephrine than norepinephrine. This then led to the bigger study that Nir already showed this data in the first 7 minutes of this conference, looking at epi versus norepi. This was, quote unquote, the biggest trial of noted randomized 57 patients to epi or norepi. These are Acutami shock. And what we saw is very similar to what we saw in the prior studies. Mean arterial pressure went up similarly in the two groups, but we had more lactate in the epi group. We had more tachycardia in the epi group. Cardiac double product, a surrogate of myocardial oxygen demand, also went up. What's interesting in this study is this study was actually stopped early. Because even though this was such a small study, they showed a statistically significant and exorbitantly visually stunning difference in the percentage of people who went on to refractory shock, 37 versus 7%. And 60-day mortality was unchanged, but again, this was a small study. So this was stopped early due to harm seen in the epinephrine group. This data has been kind of buttressed, I would say, not validated, but buttressed through different meta-analyses and registry studies. This is just one figure showing that when we kind of pool all this data together, that the odds ratio of increased mortality was 3.3. Then they did like 4 or 5 different sensitivity analysis, and that odds ratio just went up. Okay, I'm not showing you all of that data. And in this, by the way, epi was still used in about 37% of patients. This is a combination of cohorts and some studies. So it's still being quite widely used, and mortality was about 50%. And when you look across the subgroups, it was present, there wasn't any one subgroup that this didn't necessarily apply to. So in conclusion, I'm going to finish shockingly with maybe 30 seconds left. Epinephrine use is associated with excess lactic acid, that's mainly type B, tachycardia, increase in myocardial oxygen demand, and increase in arrhythmias, worsening shock in clinical studies. Norepi seems to be clinically superior. This was a randomized trial, but it was stopped early, and it is still small. I did not show you data, but there's other data showing superiority of norepinephrine to dopamine in different studies as well. So with that, I thank you.
So let me ask you, I mean, what do you think the issues are as far as the field, adoption, et cetera? I mean, the data is pretty clear.
So you know, it's interesting. One of my colleagues from Italy came up to me right before this. He's like, just so you know, we always use epi. And everyone lives.
That's my point.
Right?
Right.
And so, you know, I think at the end of the day, all of our data is very confounded by either small sample size or different inclusion criteria for different patients, right? And Acutami shock is very different than, I tend to, the vast majority of shock I see is heart failure shock as a heart failure physician. So one, these populations are different. But to me, I think when I look at the sum of the data, I wouldn't reach for epi first. But to be honest, I haven't been reaching for epi first. It's been a long, like I reach for epi when I've post cardiotomy, they get a lot of epi because the thought there is it's myocardial stunning and the offensive agent has been removed. But even there, it's been shown to increase lactic acidosis and so forth. But the times I use epi is either the post-surgery, which is not in my control anyway, or when everything else has failed, right? Because epi is the drug that raises you from the dead. So when you're on your 4th presser, yes, they're on epi, right? And I usually will start it as my 3rd or 4th presser. Obviously, I always want acute mechanical circulatory support before we get to that point. But for patients we can't do it on, patients who are not thriving on it. But it's really not the first line of choice because it increases myocardial oxygen demand. I would make the argument, though, that I think more and more we're moving towards mechanical circulatory support devices because all of our agents increase myocardial oxygen demand. Epi just does it more. But it's not that milrinone's good for the heart or dibutamine's good for the heart. I don't, you know, my typical practice is, you know, if I can get away with one inotrope or a low dose of one presser, great. And it's not epi first. I typically will do milrinone or dibutamine as an inodilator, and then I typically will do levofed. But then if that fails, I do AMCS.
Got it. Let's ask the panel for comments. I have another thing you could add, though, to your first slide. Epi's prothrombotic. It's platelet activator. Right.
I couldn't include all of it because 7 minutes is actually quite short.
Right. Just put a bullet in there on your first slide.
I had like 6 hidden slides.
One of the key factors you showed in many of the slides is that for the same mean arterial pressure, so for the same vasopressor effect, you have tachycardia, but you would expect to have a higher cardiac index, but the cardiac index is similar. So this means that stroke volume, stroke index is lower. So this is perhaps not so dangerous in septic shock. That's why mortality differences are not so different in the Anand trial published in Lancet, but in cardiogenic shock, this can be really dramatic. And I guess that this can be one of the mechanisms that we should pay attention to. And if we look more broadly, for the dopamine trial, we had also more tachycardia with dopamine, more arrhythmias, and an increased mortality. With epinephrine, you have more tachycardia, more arrhythmias, because in my birth trial, 22 patients under the 100 patients were stopped norepinephrine and switched to norepinephrine because arrhythmias. So this is among these adverse effects that we should pay attention to. And so perhaps we should discuss at some point other less tachycardic agents. And so would you like to comment on non-adrenergic agents? Do you switch off to vasopressin more rapidly, or do you consider angiotensin at some point for these patients?
So, I mean, I've used angiotensin here and there, but it's usually, most of my patients have a terrible index, and I can't justify using angiotensin. But for vasopressin, you know, and then there's this thought of a relative deficiency in heart failure patients. So we do vasopressin. At that point, we almost always have a SWAN. So we're looking. If our SVR is 3,000 and our index is 1.2, we're reaching for a device, but 2, we're not reaching for vasopressin as we're waiting for the device. And, you know, do I reach for epi sometimes if I have like 40 minutes until the cath lab's going to come in, right? As a heart failure doc, I can ask for a lot of stuff, but unlike David, I don't do it, right? So as I'm waiting, you know, do I use epi sometimes? Sure, but it's not my first choice. Neither is vaso, but, you know, I think you're not going to see a study of vaso in this because we're not going to reach for it routinely.
Would you ever consider adding ivabradine to catecholamines to offset for excessive tachycardia?
I have not considered it, but I might now. I think that's an interesting concept. I think you don't really get hypotension, so it wouldn't be a bad thing to do. To me, I think I wouldn't do that before, if I wouldn't do epi with ivabradine. If I was on the agents that I want to be on, but I see an excessive tachycardia, it would be a reasonable thing to try. I haven't done it, but just because I haven't done it doesn't mean it's not. Have you done it?
Couple of times with the butamine, not with the...
Yeah.
Yeah.
Yeah. Just because I haven't done it doesn't mean
We gotta move.
I shouldn't.
No, just real quick. Esther, thank you for a beautiful talk, followed by a lot of hand waving that gave us right answers.
There
No
you go.
problem. Hand waving is my thing. All right.
David will hold your